Good morning, everybody. I am so sorry that I cannot be with you there in person. Funny story. I am not allowed to fly right now because I have blood clots in my leg. How did you get blood clots, you might ask? Well, turns out it's really, really important to do what you know to do, right? Knowing we must move often and frequently is not enough if you don't do it. I had many long days sitting at my desk. I have a beautiful sit to stand power desk, but I have so much junk on my desk that when I raise it up, things fall off the back. So guess what? Silliest reason. I sat for several days, long days without getting up. And then I had a day and a half in bed with the flu. Guys, that's all it took. That's all it took for blood clots in my leg, which means I cannot be there with you in person, but I am here live with you right now on camera and here to tell the story that knowledge alone doesn't prevent the harms of immobility, right? We must practice what we preach. So with that preface, I'm going to jump in today to talk about the importance of the interdisciplinary approach for safe, early, continuous mobility. So what is safe, early, continuous mobility? You're at a safe patient handling conference, right? What this means is that every patient will achieve their highest level of functional independence that is safe for them, safe for the caregiver, regardless of their age, regardless of their medical condition, and regardless of their physical environment. We want to make sure that mobility is safe, not just for the patient, but also for the caregiver. And you've been learning already this week, lots of tools and tips and tricks to make it safer for you. What I'm going to throw in the mix today a little bit more, and you've heard some of this already, but what does safe early mobility look like for different team members? This is a team sport. No one discipline can do it on their own, right? Many of you in the room have probably tried already and you're frustrated. You're like, why won't everybody get on board? So what I want to go through today is touch on the different roles of different disciplines. And we're going to hear from those disciplines themselves about the importance of mobility from their perspective. Early, it means that we never delay mobility other than because moving that patient would make them worse medically. So we don't wait till they're off the vent. We don't wait till they're discharged from ICU. We don't wait for therapy. We don't wait until they get X, Y, and Z. We do wait till it's safe. If they've got a potential fracture, we do wait until that's been screened out. But we make sure that the reason we are waiting is not for any reason other than to move them right now would potentially cause them more harm. And then continuous, this idea that mobility is not just once a day. We know from many of the studies that once a day and adding more minutes to that once a day doesn't help us any. We've got to mobilize frequently throughout the day. That means across all disciplines, throughout the entire 24-hour shift and across all care settings. So that's really what we're going to talk about today. I also want to just preface this whole concept with the fact that there are three kinds of movement that we need to think about. We have passive movement, we have active daily mobility, and we have structured rehab. We're going to play a short video showing the difference. Hopefully you can hear this on YouTube. There are three types of movement to consider. First, passive transfer, where the patient needs to be moved without actively participating in the movement. For example, if they're sedated and they must be moved to a special diagnostics table, or if they've had multiple trauma and need to be moved onto an operating table. Secondly, during daily mobility, when the patient is participating in daily activities during hospitalization, such as getting up for meals, going to the bathroom, performing daily hygiene, etc. In this case, the goal is to stay active and to avoid hospital deconditioning as the patient recovers from their acute illness or injury. And third, during rehabilitation, when the patients are actively trying to increase their independent mobility through a structured exercise and activity program. I'm not endorsing any particular equipment. What you see in my videos is what I have access to in my studio here. You are in the prime location right now to go around the vendor hall, look at different types of these equipments, get in them. Go to the vendor hall, get in the slings, try and move, try and do passive mobility, think about active daily mobility, look at structured rehab. There's lots of different tools to help us do that. And strongly, strongly, strongly encourage you to get in them, feel them for yourselves so that you can leave this conference really well informed with how different styles fit, how you feel about them and how they would work in your facility. The reason I showed this slide, one day makes a difference, right? This is your to-do list. You've got to get your milk, check. Pick up the kids, check. Mobilize your patients, check. Look at days 1 and day 2. Contractures begin within 24 hours. Muscle atrophy begins within 24 hours. In fact, we lose about 3% muscle strength every day we stay in bed. Our cognition gets a little worse every day we stay in bed. Do you think that maybe impacts falls? Absolutely. Do you think it impacts the patient's ability to go home after discharged? 100%. We know that about 40% of patients over the age of 70 are discharged to an institution where they could have gone home had they remained mobile and retained their functional independence while they were in the hospital. So we cannot wait a couple of days for therapy, a few days till they're off the ventilator. We must start from day 1. Mobility is medicine. It should be considered a vital sign or a vital medicine, just like blood pressure medicine, antibiotics, any other meds that we know are crucial to that person's recovery. Use it or lose it paradigm is particularly relevant to immobilized patients. And bed rest should be the exception, should not be the rule. We've got to get rid of those bed rest orders, folks. Early, upright, often. Sit up, stand up, walk. It's not rocket science. We've got to just make it happen, right? Talking about it, knowing about it, having a policy about it, having a team, having whiteboards, having communication, having documentation. That's all great and it's all necessary. But if we don't actually do it, we're not going to get the outcomes for our patients that they rely on us to provide for them. We must make sure that we are not unintentionally causing our patients more to recover from when they leave our facilities. We only want them to recover from what they came to see us for. We don't want to add recovery from what we have done to them in the hospital. One of the analogies I use here is when we take our car in for an oil change, or that it's making a minor noise and maybe we need new brake pads or we need new something and it's minor. How would we feel if our car comes out of the shop with a banged up fender, with 3 wheels, with only going into first gear and our transmission is broke? That's what we're doing to our patients when we don't get them up. We're having them leave our body shop, our hospitals, in worse shape. We might have fixed the sound that the car was making. We might have fixed that minor thing, but the problem we've left them with is worse than what they came in with. So this is our opportunity, guys. This is what we're trying to accomplish. We have many recovery moments throughout the day, better than one 45-minute exercise event. If we can do both, even better. And patients should change position relative to gravity every hour during waking hours. This was a study that I did with Dr. Vernikos in 2020. So this slide here shows us the changes that happen with astronauts, peak athletes. These are not patients, But look at the similarities that we see between our patients and these peak athletes. When these athletes were put to bed, the only thing wrong is they were not allowed to get up. Everything else, their bodies was perfect. Decreased stroke volume, increased heart rate, increased viscosity, decreased lymph flow, decreased functional residual capacity, VQ mismatch, decreased residual volume. Look at these effects of bed rest alone. Musculoskeletal, 10% loss of strength per week. No disease, just bed rest. So we know from all this work that Dr. Vernikos and her team have done at NASA that immobility is an independent predictor of poor outcomes. Now, when we look at this, you look at this and say, Margaret, this is an old reference. It's a 1993 reference. Yeah, it is. What have we learned? What are we doing differently today? We've known this since the early 90s. In fact, we've known it since the 19th century. But knowing it doesn't change these outcomes for our patients. We must do something about it. Functional level matters. We know that functional level at discharge is more predictive of readmissions than comorbidities. The higher the function at discharge, the less likely the patient will be readmitted. This is more pronounced in our medical population than it is in our neuro or ortho. We also know that clinically, patients' ability to transfer from bed to chair and to toilet to perform basic activities of daily living, they're key determinants for them to get home, right? If that patient can't get from a bed to a chair, where are they going to be discharged to? A nursing home. So this is the graph showing that the black column is low FIM scores. This is functional level at discharge. The low functional level, the higher the readmission rate. The black columns are our medical population. The gray is our neuro. The white is our ortho. So we see it in all different populations, but most pronounced in our general medical population. Why is weight bearing important? We must get our patients up, not just sitting, but we must get them standing and walking. Why? Because weight bearing is what maintains our calcium homeostasis. We also know that bone homeostasis is involved in endocrine function, in insulin resistance. We know that upright positioning is the only way to combat sequelae of loss of gravitational force. The only thing that will cure and prevent immobility syndrome is mobility. There is no pill. There is no procedure. We've got to get our patients up, but we've got to do it safely. Sitting is better than lying, but we don't get the weight bearing. We don't get this upright positioning because most of the times patients slouch when they're sitting, right? We get limited gravitational engagement. Sitting does not improve our standing balance. If we look at our fall patients, so many of them have balance issues and have impaired gait. If we do not work on balance and gait, we are increasing our patients' risk for falls. So again, we've got to get to that highest level of mobility. It's important. It's important for the patient outcomes. It's important for our nursing metrics, our physician metrics, our therapy metrics. It's important for the fiscal responsibility of our facilities. It impacts readmissions. It impacts length of stay. It impacts our falls. It impacts our pressure injuries. Mobility is the key to all of these pieces. So there's lots of opportunities for mobility throughout the day. How do we do this little and often throughout the day? We have focused therapy. We have combining with nursing. We have adding patient initiation and increasing participation in their own care. In part 2 of this section, after break, we're going to see what this actually looks like with a range of different patient scenarios. Understand that by saving a few minutes now, we might be costing ourselves more minutes later. And then this thought of the other 23, even if therapy was to see every patient throughout the hospital, you've still got 23.5 more hours a day. What are we doing? So early mobility, safe early continuous mobility is everybody's job. We're going to hear from some of the disciplines about their role in safe early continuous mobility. The SECM team leader, it doesn't matter the title. It could be a physician, a nurse practitioner, a PT, an OT, an RN. The important element is that the person who leads your program has strong leadership skills. They know how to build a team. They know how to communicate really well and understand the workflow of all the disciplines, because we must work together, but understand and have mutual respect of the key things that are important to each discipline, because those responsibilities for each discipline don't go away. We have to learn to work smarter, not harder. The leader should be able to work with leadership, to do reports, audits, metrics, to be able to speak the language of leadership and the language of the very frontline staff and everything in between, so that we can make this relatable for each of the stakeholders. So what is the role of the providers? Educate patients and their families, write mobility orders. Let's get rid of those bed rest orders unless there is a medical indication for them. Some facilities are going towards expirations, just like restraints with their bed rest orders. Know the mobility level and the goals for your patients and make that part of your daily rounds. Be asked to be alerted if the patient is not meeting their mobility goals or if their mobility declines without a medical or any other explanation. Let's hear from Dr. Patel, what in her words.
We all know that functional status decline commonly accompanies hospitalization, right? Many people, especially those admitted to the ICU, face functional comorbidities or decline for even a year after hospitalization. Awareness is one of the key things that I see that would improve patient mobility and collaboration amongst the teams. Awareness that some of the common things, poor sleep, poor nutritional intake, it doesn't have to be the patient who has a fracture and can't move, pain, polypharmacy, inappropriate orders, bed rest on a patient that may not need to be on bed rest. These are all factors that play a role in affecting patient mobility, and they can all be mitigated by, hospital-based early mobility programs.
Case managers, discharge planners, social workers include mobility goals as part of the discharge plan from the day of admission, even if they're in the ICU, and then ask daily. Make it one of the questions that when you have the charge nurses report to you as a case manager, do they have all their consults set up? Are they ready to go home? What are they waiting for? Is their discharge plan still going to work? Is their mobility still at the level it needs to be for them to go home? This ties into some of those stat orders that therapists get when the patient is ready to be discharged, and placement evaluation, when you may have seen them as a therapist several times and discharged them from your care, but then they've sat for a couple of days and they can't get up again. So add mobility plan equipments to daily report, mobility language at handoff reports, make that part of the daily conversation at every level. Let's hear from Kaylee Dayton, a nurse practitioner, about the role of nursing in early mobility.
I'm Kaylee Dayton. I'm a nurse practitioner, but I worked as an ICU nurse for 7 years.
And so you've had a role of nursing in early mobility programs across the care continuum or through ICU and acute care. Can you speak to us, Kaylee, about the role of nursing and what a nurse can bring to the table in an interdisciplinary team for promoting a culture of safe early continuous mobility?
When I started my RN career, I was in an ICU that mobilized almost every patient on a ventilator throughout the day, 3 times a day, unless there was a contraindication to mobility, which are few. And so it was just part of the culture to assume that I'm going to help get my patients to the chair and that they're likely going to walk, that they're going to preserve their baseline throughout their time in the ICU, unless there really was an exceptional status change. And so as a nurse during day shift, when physical therapy showed up, I knew that I was going to be ready and get my patient up. We're going to walk through the halls. My patient's going to sit in the chair. I'm going to get my patient back to bed. And on night shift, there was no physical therapy. So it was just me, my respiratory therapist, and my CNA walking our patients on ventilators through the hall. And so we just understood that that was a big part of our job. And because everyone did it and everyone did it together, everyone was comfortable with that process. We all had that skill set, kind of like pronation is now after COVID. Everyone knows they jump in, they get it done, and you're done with it. And that's how mobility was. And because it was so frequent and with all patients, the safety just felt so much more assured, because patients were strong enough to basically get themselves out of bed, get themselves to the chair. Even during COVID with nurses, we were alone in the room with patients. They'd stand up, get themselves to the chair with a standby assist. So that it was just an assumed part of the role that I was going to keep patients as functional as possible, even though that they were critically ill. And then later, when I went to a step down unit, as a travel nurse, I was in a different hospital system, different ICU culture, and I was receiving patients that were coming out of the ICU that did not have that kind of mobility throughout their time in the ICU. And it felt unsure, it felt dangerous. And I felt a big burden as a nurse to try to then get them ready to go home after they had not been mobilized. And that's when it became a lot more difficult, but I could feel a greater sense of urgency as a nurse to make that happen. Especially in the ICU, and I think for any part of acute care, your shifts fluctuate so much, your acuity with your patients fluctuates. There are certainly times I know as a nurse when I can't even leave my patient's room because they're actively crashing. I can understand that. For most shifts, for most normal workloads, you just have to integrate it into your normal part of the shift. I don't let my patients eat in bed. So if they want to eat, they have to get out of bed. They don't take meds in bed. If they're taking orally, they need to be up in a chair. So setting that standard, I'm just encompassing that in the normal routine. It's part of my neuro exam to get them out of bed. I trust evaluating for ability to follow commands, limb strength, things like that as I'm getting them up. As you integrate it into part of your process, getting them to the commode, it just becomes a routine, a rhythm. And when your entire team has that, you're supported in that as well. It's not just me alone as a nurse having to do this. I know when my CNA comes, they're going to be comfortable and prepared to do that as well.
So it sounds like having a culture and having that expectation is a big part of it. And I think many facilities, many nurses that we talk to struggle with feeling like they're kind of swimming alone in an ocean and they're trying to go in the opposite direction to everybody else. And that's really hard. And so I heard you say more than once that culture is such an important piece of this.
And it really impacts the timing and the time it takes to mobilize patients. In that awake and walking ICU, patients are intubated and they're up walking within hours afterwards. I've walked patients on a PEEP of 18 and 100%. You're just walking them throughout that time. So it does not take 5 people to get them up. It takes 1 person as a standby and then maybe even 3 people to walk them around the unit. That changes things. Whereas when we get patients from other facilities that have been sedated and immobilized, then we're trying to mobilize them. That's when it does take so much more time. It's greater risk. It's scarier. So I think preventing that scenario for most of our patients is the key to success.
Sure. And again, if I can just point out something I heard from you that I think just resonated, prevention saves you time, right? Because
Rehabilitation, not just rehabilitation, but if we focus on prehabilitation thinking, they're critically ill, they're at high risk of ICU-acquired weakness, we know that we can reduce that by mobilizing them now. It's going to be easier, faster, quicker now than later. Mobility is one of my greatest tools to treat agitation. So for night shift, for example, I know that if I have my patient up in a chair until about 9 o'clock at night, I mobilize them, then I tuck them in for night. That is how I win a quiet night. But if I don't have the skills, or I'm not allowed, or I'm not even thinking about mobility, I'm much more likely to have an agitated patient throughout the night, or I'm much more likely to sedate them, or they're going to become harder to mobilize the next few nights that I have them. So I need that tool in order to treat delirium. If they get confused, agitated, they're sundowning, mobility is going to be one of my greatest tools to keep them safe and to keep it manageable for me. We all know what it's like to treat a delirious patient. It's a lot of work. So that's how I reduce my workload, is spending 10 minutes on mobilizing a patient and then having hours of peace. When we compare the workload, I don't have the hours calculated, but I think with sedation, there's a laundry list of things that we have to do. We have to run at least 2 sedatives, usually propofol, fentanyl, sometimes 3 sedatives going at a time, depending on how fast the rate is. We're switching bags out, we're double checking with another nurse, we're wasting. Sometimes we're hanging a vasopressor to compensate for the sedation. That's a lot of in and out. You think about COVID, all the PPE that was going on. That's a lot of work just to keep those drips running, and then turning Q2. And then you get a pressure injury, and then you have to treat that. You have to chart restraints. Then you have to deal with the delirium later. There's a lot of extra work that happens that we don't necessarily perceive as extra work because it's the norm. Whereas we exchange those efforts and a lot of times decrease the efforts when we prevent delirium, prevent IC cord weakness. The patients say calm, cooperative. You're not wrestling the patient. You're not having to haul them out of bed.
So amazing insight from Kaylee on the time saved, and just this thought that mobility is part of everything that the whole team does. It's a routine part of care. And if we can do it in the ICU, we can do this anywhere. Yes, there's a lower nurse to patient ratio in the ICU, but there's so much higher acuity. We have multiple team members in the floor side, the non-ICU, that we can really leverage to promote this culture of mobility. The other thing I thought was really interesting about Kaylee, she talked as a nurse about prehabilitation. How many of you are thinking, wait a minute, rehab, prehab, that sounds like therapy's job. But you heard from Kaylee, this is a tool that her and her nursing team have. Therapy augments it, but the tool is theirs. This is nurses' tool to help them do what they do better and in less time. It's just a case of changing the way we think about it. We also know nurses are knowledgeable about how the patients move and tolerate mobility throughout the day, understand the importance, understand the mobility levels, what that means the patient can do for themselves, and where we need equipment, promote delirium screening, work with other disciplines to promote best practice, and encourage the patients to do things for themselves throughout the day. It is absolutely within the nursing scope of practice. You'll see here, not just physiological basic, physiological complex, behavioral, safety, community, and even in some of the health system responsibilities for nursing. Anywhere you look, mobility helps you accomplish your goals. So now let's hear from our own Ronnie. And many of you may have seen Ronnie this week. He's there with you. And if Ronnie, if you're in the room, hi. I can't see you guys, but let's hear from Ronnie.
Can you speak to how you build mobility into all the things that you do with your patient in a day?
I would say it's not a once a day task. You know, with our heart patients, we move them 4 times a day. Everybody, because it's helping the circulation, it's helping the breathing, it's helping a whole lot of things. So once a day, when I hear once a day, no, it's not once a day. It's as many times as you can do it.
Right, and Ronnie is a CNA and a certified safe patient handling CNA and an amazing mobility advocate for his patients. So you don't need to be a therapist. Ask the patient if they can do something before you do it for them. Remember, when you are their muscles, they lose their own. Allow patients time to work through their activities. Let them use their own muscles. So when it comes to therapy, therapy is part of rehab, but it's not the same thing. There's lots of other things that therapy are also looking at, but we must work together. Rehab's role, we want to make sure we're attending multidisciplinary rounds, discuss mobility and rehab goals, evaluate patients, look for those specific structural and functional impairments that we need to restore, work with other disciplines, tips and tricks throughout the day that we learn as part of everything we do for our patients. But other disciplines don't necessarily learn those things. For example, nose over toes, scoot your butt to the edge of a chair, stagger your feet before you stand up. Little things like that can make all the difference in the world. Let's hear from Dr. Jamie Haynes about her opinion on the role of therapy.
The research shows, especially in ICU and acute care, that we need to get people up more often, and physical therapists can't be there more often. And so when we work as a team, the therapist is the one that's challenging that patient and is pushing the limits, is in really promoting recovery very specifically in that time frame. But we also need the nurses who are with that patient hours upon hours to reinforce that for us. And so if it's using equipment, if a patient can sit up at the edge of the bed, then they should be sitting up at the edge of the bed to take their medications or eating. If the patient can get into a chair, using the equipment to get into a chair to really follow through with the ADLs that they're going to be needing to do at home. And so, I think that conversation is really important. And we know that when patients have success on things that are important, like, I really would like to brush my teeth today, I'd really like to sit up at the edge of the bed and eat, I'd like to groom myself, we know that releases dopamine, and that's great for the brain and for recovery. We know that doing things that are salient are important. And so physical therapy may do that, or OT might do that once during the day, but that's the opportunity that the nursing care has, is that continuing to reinforce saliency for enhancing recovery, because everything they do with those patients is important to the patient. And so I think that's another thing that maybe nurses don't realize, that little bout of reinforcement 4 or 5 times a day is so key in recovery.
And then let's hear from our occupational therapist.
We're very fortunate at our hospital to have a wide variety of equipment to use. So in our ICU, we have ceiling lifts, we have dependent transfers lifts, we have electric sit-to-stands, we have manual sit-to-stands, and we have the friction-reducing slide sheets. So we've got a wide array of tools to use with our patients. I think of maybe some of our more obese or heavier patients that are quite dependent in the ICU traditionally are not moved as much as some of our smaller patients. And so I like to get the ceiling lifts involved for safety for us and for the patient the first couple times that they're out. So we may use the ceiling lift, and even if we're not sure if the patient will need it or not, for safety, we'll put them in the sling and have them sit at the side of the bed. That gives us a safe gauge for what they can do, and that will help transition. With our electric sit-to-stands, I like to do ADLs in those. Traditionally, we don't lay in bed to brush our teeth in the morning. Sure. So if I can get them sitting at the side of the bed and even standing in one of those lifts, depending on the lines and wires, if I can get them up to the sink or even pull the tray table up and give them an activity to do in standing, if they can tolerate it, we'll do that. And then progress them through to the manual sit-to-stands, where the patient has to pull themselves up to stand, but they always have that pad there to be able to sit back down on and rest if they need to abruptly. They feel safer, we feel safer, and it helps to progress them through that activity, moving towards ADL that's meaningful.
And additionally, we have respiratory therapy. These are people that are coming in, working with the patients who could be contributing to safe early continuous mobility. Pharmacy, looking at what medications the patient is on. Can we get them off sedation? Can we get them woken up earlier? Can we use pain meds instead of sedation meds? Can we look at different meds that aren't going to increase their fall risk if it's somebody at high risk for falling? Champion roles, so peer leaders. We need to have peer leaders on every unit to be able to promote this culture of mobility. We need support from our senior administrators and leadership, making sure we're protecting time for training, allocating resources, adding SECM metrics to the agenda and to dashboards. Management, making sure we are supporting all of our staff on the unit, making sure everybody feels that they are proficient, that they've had the training that they need, and then holding your unit accountable, including yourself. We are all together holding ourselves accountable to that higher level of patient outcome. And then we have the patient and their family. This is a big one that we need to address and empower our patients and reframe the expectations that when they come to the hospital, laying in bed is not what's going to help them. They've got to get up and moving. Changing that paradigm is super important if we're going to accomplish this culture of SECM. Let's hear a little bit from Chris as from the patient's perspective.
If during that screen If that were part of the practice of every caregiver, every therapist, every nurse, every CNA, do you think that would have impacted your mobility when you were in the acute care hospital, when you were in the nursing home? What difference do you think it would make?
Absolutely. For one thing, it shows to me that the person that I'm working with, I has confidence in me, but I have confidence in them, because if they're doing a screening, they're actually interested in what are my limitations. They're watching what I'm doing. And you notice, what did that take? 30 seconds? That didn't take any time at all.
That's
And
right.
one of the things, caregivers, I don't have time to do that. And the time it took you to say I didn't have time to do that, you could have done that.
So Chris is talking from the patient perspective, how important it is to do a screen, to be mobile, to give him a chance to move himself. So we're all on team patient. The common goal is maximizing patient outcomes. Therapy is focused on movement and restoring function, but with one patient for 30 to 40 minutes, it's rare in acute care for a therapist to get 60 minutes a day, right? Some of you are probably going, what planet are you living on, Margaret? The nurses are with the patient the other 23 hours. Our other team members can contribute. And in part 2, we're going to see what this looks like. Frequent mobility is what's needed for homeostasis. Remember, recovery moments build up throughout the day. We want to get to that highest level of mobility. We need to use the safe patient handling to prevent falls while we mobilize, right? We need to plan for our program. We need to include our stakeholders. Safe patient handling devices are the answer to the tension between falls and early mobility. If a patient is at high risk for falls, get them up. If a patient is at high risk for pressure injuries, get them up. If a patient is at risk for delirium, get them up. Like you heard Kaylee say, if the patient is sundowning or confused, get them up, but they might fall. Put them in a walking harness. Use a non-power or a standing aid with a removable foot plate. We have tools to overcome this tension, right? So make sure it's safe for the patient, set a mobility goal. Based on that goal, determine the position or method for building mobility into daily care. Screen your patient's mobility, make sure the right equipment is being used. Do the mobility, document it. Easy, right? Lots of different tools. You've seen all these. Go explore and play in the vendor area. Easy things. We'll see these a little bit more in our next session. I want to make sure that we leave time for questions, but these are Katrina's easy things. We'll talk about these more next, right? Immobility should be avoided. Mobilizing patients improves outcomes, shortens length of stay, decreases cost of care, reduces harmful complications and secondary problems. It must be interdisciplinary. It's a team sport. The goal should be team patient. Safety is important. Gait belts do not reduce injuries. We must go to the safe patient handling tools. And teamwork and collaboration will improve patients' quality of life, caregivers' quality of life. And one parting thought from Kaylee, and then we'll have some time for questions.
Mobility is a sacred part of our stewardship. We get into medicine because we want patients to survive and thrive, and mobility is going to make that happen. During this crisis, staffing crisis, we can't afford to continue process of care that keep patients in our facilities longer, getting more complications. And so we really need to band together to look at the big picture and figure out how to work smarter, not necessarily harder, because what we're doing right now is very hard. But when we change the timing and the approach to mobility and work together, this is not just nursing's job, but when everyone feels supported, everyone's going to be more willing to work together. And this changes the dynamic within our units. And that's what we need. We need to feel camaraderie, fellowship, and that we're all working together, and mobility is going to be our common ground in order to make that happen.
So mobility is our common ground. Thank you very much. I know that we have a 5-minute break coming up now. So if anybody has questions, let's pause and take those questions.